morning. I'm Dr. Kate Leiretana, and today I will be talking about HIV and aging. HIV and aging is something that could be a new topic for us. Feeling natin na hindi natin siya pa kailangan intindihin dahil lagi natin naririnig na ang babata ng mga na-diagnose natin na people living with HIV, especially sa mga new cases. Ngunit kailangan as early as now, maging handa tayo sa possibility of managing patients who are above 60 years old. Sometimes these can be new clients diagnosed at that particular age group, or because of effective antiretroviral therapy, our patients live long to reach this age. So bakit mo kailangang malaman ang HIV and aging? Tulad ng sinabi ko, mas madaming PLHIV ang mabubuhay ng mas matagal dahil sa effective antiretroviral therapy. Kung maaga kang na-diagnose ng HIV, especially at 20 years old, with a high CD4 and wala kang bisyo like smoking, drinking, or paggamit ng bawal ng gamot, maaring tumanda ka the same as non-HIV population. This was a study demonstrated in Canada. Pero kailangan natin isipin, no, ang lugar kung saan ginawa ang pag-aaral na to ay isang first world country na kung saan nasasagot ang mga pangailangang basic ng isang tao. So, importante doon na secure ka, meron kang tahanan, meron kang adequate nutrition, and meron kang pinag-aralan. So, sometimes these factors also help, no, in having a long and good quality of life. Meron din tayong mga new diagnosed na above 50. However, unfortunately, wala masyadong information about HIV and aging, lalo na sa isang developing country tulad natin. Kulang din tayo sa kaalaman kung ano ang sexual beliefs and practices of older people. Do they still have sex? Do they still use prevention? Relevant ba sa kanila ang paggamit ng condoms, PrEP, or PEP? So, ito yung mga bagay na hindi natin alam. No? So, maaari talaga tayong magkaroon ng aging population of newly diagnosed patients. As older people, mas maraming comorbids ang pwedeng makita rin. Mas marami ring drug interactions dahil sa maraming gamot na iniinom, side effects that can affect adherence ang older PLHIVs. So, sino nga ba ang part ng aging PLHIV population natin? Ayon sa ating May 2022 HARP, ang above 50 ay only 3%. In the US, mas malaki ang proportion ng newly diagnosed na age 50 and above. Wala tayong readily available data of how many among current living PLHIV ang above 50. Pero nagsaliksik ako sa sarili kong mga patients at nakita ko na 4% of current PLHIV sa SHIP ay age 50 and above. Sa US, in 2015, almost half ay aged 50 and above. So these are current total PLHIV alive on ART. So mas marami ang proportion ng older na PLHIV sa US kumpara sa Pilipinas. So, ito yung age distribution ng current PLHIV sa US. Nakikita natin na ang majority sa kanila, sa blue bar, are older na. No? Ang peak ng kanilang curve ay nasa 45 to 49, compared to 2001 when they had a younger population. So nagtanong ako ngayon sa aking mga pasyente na age 50 and above at tinanong ko sa kanila, ano-ano ang concerns ninyo bilang PLHIV at this age? And ang dami pala apparently ng concerns nila. No? So ni-classify ko siya as to whether it's medication-related, musculoskeletal or bones and joints and muscle, weight-related, comorbidities o yung mga iba pang sakit na meron sila, sleep and memory, sexual drive, at ang social issues. So, importanteng makita dito na despite being a little bit older than their counterparts, they still feel the same social issues such as yung stigma of the disease, no? Even at this age, let's say 10 or 15 years na silang living with HIV, they still fear how people might respond kung alam nila na sila ay merong HIV. Worried din sila, no, sa medical insurance, travel restrictions, at iba pa. So if you can see here, definitely age plays a role sa mga complaints, no? Lalo sa musculoskeletal, no? Ang sakit ng kasukasuan ko, yung balat ko, hindi na siya makinis at supple and taut, no? Nawawala na siya ng kanyang flexibility, ganyan. So, dahil sa dami ng maaari maging problema, kailangan bilang healthcare provider, ready tayo pagtugunan ang mga to dahil tayo unang tatanungin nila. So let's break it down. Mas concern ba ito ng PLHIV versus non-PLHIV? Pare-pareho naman tayong tumatanda. So importanteng tandaan, ang isang PLHIV ay may mas malaking tsansa na magkaroon ng multiple comorbids. Example, may hypertension, may dyslipidemia, may diabetes, may cancer. Can exist in one person, no? Multiple medications, syempre, multiple comorbids nga. HIV-associated non-AIDS condition. So later, we'll learn about what these are, no? Increased vulnerability to stressors and changes in physical and cognitive abilities. So here we see naman ang isang prevalence, no? Age, sex, standardized prevalence ng iba't ibang mga sakit sa mga PLHIV versus negative. So the black circles are those na PLHIV and yung white circles is yung HIV negative. So the highest prevalence is hypertension, and here we can see na mas mataas yung occurrence niya, no? Kaysa sa HIV negative population. And if you look at it, parang lahat. Saan lang lumalamang ang HIV negative? Cataracts, osteoarthritis, retinal disorders, halos patas sa hypothyroidism, and tobacco use disorder, umangat ng very light sa rheumatologic disease, and pareho sa hemiplegia, paraplegia, and schizophrenia. But all others, mas madalas mangyari sa PLHIV. Okay. So, ito naman ang nagpapakita sa atin through the years, no, among the Swiss HIV cohort, which is a group of people na inoobserbahan mula noong 1984 during different time periods, no? Lahat sila ay merong HIV. Ano ang mga most common causes of death sa kanila through the years? Nung una, 1980s, of course, AIDS. Kasi ito yung panahon na wala pang na-discover na gamot or na-discover, nag-aaral pa lang, no, para hanapin yung gamot. In 1996 and 2004, still, most common cause is AIDS, but followed by non-AIDS infection. Hindi. Other. Sorry, hindi ko ano yung other na ito. Sorry. In 2005 to 2009, a smaller population na lang ang namamatay ng dahil sa AIDS and larger ang non-AIDS malignancy. Ibig sabihin, ito yung mga cancer that is not necessarily associated with HIV, can also happen in negative population, followed by non-AIDS infection. So, ibig sabihin, marami ng mga non-AIDS related comorbidities ang nagiging most common cause of death. And in 2007, malignancy na talaga. Halos wala nang namamatay ng AIDS mula nung 2007. And then, sumunod na ang heart. Which we know, in general, is really the most common cause of death, no? Ito ang isang comparison ng typical aging and aging with HIV based on different organ systems. Yan. Let's focus on vascular diseases. So here we see for HIV, myocardial infarction, and cerebrovascular disease are 50% higher compared to the HIV negative population. I mean, they still have CVD, but mas mataas by 50% in HIV. Okay? Sa cancer, less common na nagiging problema ang breast and prostate, whereas in typical aging population, mas madalas makakita ng colon, prostate, and breast cancer. For kidney naman, for the HIV negative, the end stage is usually secondary to diabetes and hypertension, whereas in HIV, immune activation ang nagiging sanhi ng renal aging. Okay. Interesting to know also na for depression, it occurs 3 to 5 times the rate compared to negative HIV. And in typical aging, it occurs less commonly as they grow older. Okay, so yan ang mga pagkakaiba ng aging process ng HIV positive and negative population. So the question is, bakit at increased risk ang PLHIV? So we've seen all the evidence that state that in certain disease conditions, talagang mas mataas ang risk ng PLHIV. First, we have people who are long-term survivors. They have been living with HIV since the early 1990s, and sometimes they were exposed to legacy drugs, or ito yung mga older generation na antiretroviral natin that were discontinued eventually because of the harmful effects they have on our organs. No? Even if you discontinue it after the evidence shows na it's harmful, nagawa na yung damage. Okay? But we must understand nung mga panahon na yon, it's either you die from AIDS complications or you extend your life a little longer, pero you're exposed to medyo toxic na antiretrovirals. Second, non-adherence to ARV may increase inflammation that's already present. So I want you to remember this word, inflammation, because it plays a special role in aging. Third, sometimes because of the stigma attached to HIV, maraming mga economically underprivileged members of the population ang meron nito. No? So sometimes poor nutrition, lifestyle, and health disparity may also increase the risk for having comorbidities. People living with HIV have also a higher risk of having substance abuse, smoking, and co-infections with Hep B and Hep C, which we know can give chronic comorbidities to the liver. Ano ba yung nangyayari during the HIV process? Ito yung mga interplay of events. In the first few weeks of acute infection, HIV causes epithelial damage to our intestines. As we know, yung gut-associated lymphoid tissue natin are concentrated in our intestine, and dito usually nag-gather ang mga HIV during the first few weeks. And the epithelial damage causes bacterial translocation through the gut. And when this happens, na-activate yung mga inflammatory cells natin. Example, yung monocyte macrophage system natin, yung mga lymphocytes natin, which cause formation of cytokines and oxygen-free radicals. In their interplay, they can cause damage to cells. They can also cause a hypercoagulable state. And ito na yung simula ng maaari natin problema sa vascular tissues natin. No? Dito natin nakikita yung genesis ng the atherosclerotic plaque. And that can happen in the vessels and also all other organs. So these are the bridges towards development of our comorbidities. Other than that, we have factors such as low CD4, co-infections such as hepatitis, CMV, EBV, and HPV. Again, cumulative years of exposure to antiretroviral therapy, the aging process itself, and lifestyle, all of which serve to increase comorbidities in people living with HIV. Chronic inflammation persists even in the setting of treated HIV infection. In as much as antiretroviral therapy is life-saving and can lengthen the years of life of a person living with HIV, we cannot return a patient to his completely normal state pre-HIV infection. So ano yung best practices natin, no, for our HIV positive patients, knowing that they are at increased cardiovascular risk compared to those who are HIV negative? So HIV infected patients should be managed with aggressive primary prevention. Let's try to prevent the bad from happening even before the evidence is there. BP control, lipid control, and smoking cessation. These things can be done even at a young age. It's important that we know what their BP is inside the clinic and outside. We should be monitoring their lipids regularly. In fact, even if you have 20-year-old patients, you should do this once a year. Remember that our ARTs have an effect on the lipid profile of our patients. People living with HIV have been known to smoke more than those who are HIV negative, and the risk of lung cancer is still high. We should recognize a wider array of cardiac conditions present in our patients, such as heart failure and arrhythmias. So hindi tayo superficial management lang of the medical disease of our clients. Hindi lang magre-refill ng gamot, magagawa ng CD4 and viral load. Let's treat them just like our primary care patients. No? Full exam and laboratory tests suited for their age, but also, especially for HIV, there are some things we need to monitor even if they are younger. Let's also see if there are drug-drug interactions between what they take and what we give them. So, ito yung mga pwedeng gawin natin, no? Kung ang pasyente natin ay nasa edad 50 and above na, it helps to be conscious and prepare for the 6th and 7th decade of our patients. Let's start treatment early. If pwede, prevention, no? Maging health conscious tayo sa lifestyle ng pasyente natin. Please do ask regarding smoking, drug use, drinking, dietary habits, exercise, sex life of our patients, no? It's something that we need to ask during our examination. So we know that HIV can also present, no, in older adults. Symptoms of HIV might be missed just because hindi highly suspicious sa ganitong age group. Symptoms might be non-specific and can be dismissed as age-related. These are some of the symptoms that actually can reflect HIV itself. So that's why routine screening is recommended at a very wide age of 13 to 64 years old. Meaning, it should be part of routine healthcare. Kung annually kayo nagpapacheck ng cholesterol or diabetes, and you are sexually active, it might be a good idea to include an HIV test kasama ng mga routine healthcare tests natin. So anong pwedeng gawin natin ngayon, no, sa mga pasyente natin? We should monitor the toxicities of our antiretroviral therapy. For tenofovir, kidney, so creatinine, potassium, urinalysis, bone density, if we think that our patients are at risk for decreased bone density. So you can request for a bone DEXA scan. For zidovudine, bone marrow suppression will manifest as anemia. Lipodystrophy is a physical alteration that can be observed also. And the rest for the other ARTs. Point is, because prolonged exposure to ART also contributes to increased comorbidities of our patients, let's make it part of routine even at a young age. Let's see if the ARTs are causing harm and let's address them. If we need to switch them out to a more optimized regimen, let's do that. For comorbidities, our patients should be knowledgeable about their health status. For the blood pressure, alamin ang lowest and highest BP at usual BP. If BP is normal, sana magkaroon tayo ng habit of checking once every 2 weeks, once a month. If with BP problems, please advise them to buy their own BP app and consult a doctor or yourself if makita na medyo nasa increase ang trend ng BP readings. For blood sugar and cholesterol, these are mandatory to be checked once a year among PLHIV. This can be addressed preventively by eating a healthy diet and making exercise as part of routine. If these factors are abnormal, kailangan ma-address ng ating primary care physician. At age of more than 50, it would be nice to check the bone density using the DEXA scan. For males more than 40, prostate health should be examined, either using a screening blood test, the prostate-specific antigen, or doing a digital rectal exam to check for prostate size. If your patient has cancer in the family, for colon, age 50 and above, depende sa degree of the relations na mayroong colon cancer. For breast, there should be an annual check at these ages. For cervix, pap smear annually for those who are active. And for anal, there should be a baseline examination. During our patients' consultations, let's not forget to do a drug review. Let's check if our patients' other medications interact with their ARTs. So, for example lang, if a patient is taking simvastatin for cholesterol, which is the easiest accessible na gamot dahil mura rin siya, hindi siya pwedeng gamitin ng isang pasyenteng nakalopinavir, ritonavir, Tulad dito sa makikita mo sa kanan, co-administration is contraindicated due to potential serious reactions such as risk of myopathy, including rhabdomyolysis. So, paano natin gagawin tong drug interaction? You can use this helpful shortcut which you can actually use while the patient is there in front of you, binidiktas sa'yo kung ano yung gamot nila, and you can see the results together. Ang isa pang pwede natin gawin ngayon ay magkaroon ng screening for neurocognitive dysfunction. Elderly patients may have this, and this may cause poor adherence sa mga pasyente natin. And if our patient does have neurocognitive dysfunction, maaaring kailangan magtanggal tayo ng mga unnecessary medications para hindi sila malito. I-simplify natin yung regimen nila. Kung kinakailangan, magbigay tayo ng adherence aids, gaya ng PhilBack test, at mag-enlist tayo ng support ng kanilang family and friends. Ano yung mga example ng mga neurocognitive disorder associated with HIV? Example nito ay ang HAN, So, HIV-associated neurocognitive disorder. It manifests as difficulty with memory, attention, speed of information processing, and executive motor functions. In the US, it affects up to 30% of PLHIV. Surprisingly, sa Pilipinas, nung ito ay kinonduct sa isang study sa San Lazaro at PGH, 40% and 65.9% respectively. So, medyo mataas, yung incidence sa atin. And to think these are patients of a younger age demographic. Ano ang mga maaaring consequence ng pagkakaroon ng hand? Lower adherence, lower retention, heightened risk of mood disorders, including anxiety and depression. So ano yung maaari natin gawin, no? Um, para screen ng hand. Panoorin natin itong video ni Dr. Michelle Anlacan, isang neurologist mula sa Philippine General Hospital.
So what do you actually ask in your patient encounter? The best things to ask for are, do you experience memory loss? Makakalimutin ba kayo sa mga events, sa mga nangyari recently, sa mga appointment nyo, kung anong date na ngayon? Or do you feel that you are slower when you are reasoning, planning activities, or solving problems? Napakabagal nyo ba mag-isip or nahirapan mag-concentrate? Do you have difficulties paying attention in a conversation? Can you complete a book or can you actually complete watching a movie? And basically, may problema ba? Do you have problems in handling money, in keeping track of your medications, in traveling, using public transportation from place to place, and even using the telephone or the cell phone? Those are very good questions to ask for you to be able to peg what is their actual functionality. So treatment, this is very sad because we don't have exact treatments for it. No? So I think we could focus more on the patients who are still asymptomatic or only those who are mildly impaired. No? We can ask them to build up their cognitive reserve. No? All words, no, cognitive reserve. Liken your brain and your neuronal synapses to a tree. So there on the left, I have a tree with very few stems and branches, and on the right, I have a very healthy tree. So that's what we want to do. No, that's what we want our brain to become. We want it to become a very organized and tree with all the leaves and all the branches. How can you do this? You have to exercise. So you have to tell your patient, there is no excuse not to exercise. Exercise makes the blood flow, and it brings substances to your brain, and it also flushes out toxins from your brain. No? Even if they have a significant amount of illness or debilitation, there are still things that they can do to increase their level of activity. And aside from physical activity or exercise, they can also engage in healthy conversation and learning activities. They may be online or they can be with healthy chats with family and friends. This cognitive reserve is what you need so that when the brain starts deteriorating because of neuroinflammation and viral infection, then you have things to fall, you have reserve. Other ways to improve cognitive reserve include playing a musical instrument, having games, board games, or other games with friends. You can have pets, you can talk to them, you can interact with other pet owners, and daily walks are very, very important. And you should always be open to new learning. Being open to new learning is something that is what we call a lifelong learning activity, and it will really improve your cognitive reserve.
Isa sa mga frequent na tanong at issue ng mga aging na pasyente natin ay ang kanilang changing sexual drive. However, ito'y napaka-komplikado, no? Maraming mga issues ang maaring maging dahilan kung bakit hindi tulad ng dati ang sexual drive ng isang pasyenteng may HIV. Explore natin. Meron tayong mga HIV-related organic factors tulad ng epekto mismo ng comorbidities sa kanilang sexual drive, like mataas ang BP, may diabetes, mataas ang cholesterol. May epekto ito sa daloy ng dugo and therefore sa function ng ating mga sexual organs. Pangalawa, kung meron tayong HIV-related psychosexological issues, gaya ng takot na maipasa ang virus sa partner despite knowing what U equals U is, hindi mo matanggal talaga yung kaba na paano kung ako yung 0.001% na maaring makalusot at makapagbigay ng virus na ito sa aking partner. Ako'y kanyang sisisihin. Ako yung magiging may kasalanan kung ba't siya nagkaroon ng virus. Yan. So, maaari makapag-cause ng decreased sexual drive yan. Isa pa, ang disclosure or non-disclosure of HIV status to the partner. Meron ka kasing tinatago sa partner mo, hindi mo pa nasabi ang status mo and yet you are having sex. No? Stigma associated with HIV, body image changes. No? Ito yung mga bagay na maaari makapag-effect talaga ng ating performance. No? Meron din tayong MSM-related psychosexological issues. So these issues are particular to MSM. Gay culture, self-perceived body image importance in gay culture. So dito tayo makikita na ang mismong kulturang kinabibilangan ng isang MSM ay medyo matataas ang standard siguro, no? Or mapanghusga na hindi nila nakikita ang sarili nila as worthy, no, to be part of this. May takot na ma-judge. Importance of sexual performance, no? Kumbaga, isa siyang mahalagang achievement or skill na dapat meron ng isang MSM. Anal sex or minsan hindi pagkagusto sa anal sex. Casual sex and group sex, and recreational drugs abuse. So, napakarami naman itong mga MSM-related psychosexological issues. And then last na, ang HIV-related sexual behavioral issues. So, obligatory condom use. There are people who do not have an erection when wearing a condom, and feeling obligated to wear a condom immediately causes lack of energy or enthusiasm, no? That influences their sexual drive. So, ito yung mga bagay. So, hindi lang talagang sakit mo or organic medical condition mo ang nagiging cause ng ating mga decreased sexual drive. Marami pang iba. What exactly are these sexual issues in aging PLHIV? Number one is erectile dysfunction or ED. Here we can see that it is a growing concern definitely as you grow older, no? 70% among those who are over 70, 52% among those 40 to 70, but less of a problem as you are if you're younger. However, in HIV, it comes in earlier and can be caused by more than one reason. So if we look at the chart, again, it's divided into organic reasons or reasons that can be produced by your body or your illness, and psychological reasons. No? So napakaraming mga bagay ang maaari mag-cause ng erectile dysfunction. So if your patient complains of erectile dysfunction, hindi immediate sagot natin ay ang Viagra, no? Hindi laging ganun ang solusyon natin. It's very important to analyze ano yung root cause, no, ng inyong problemang ito dahil ika nga ay napakarami, and this is a helpful screening algorithm to know, no, what to do if your patient complains of hindi tumitigas ang aking ari. Okay. So next topic natin is planning for our patient's future. As our patients grow older, their need to utilize their healthcare increases. Habang tumatanda, mas madami ang pangailangang medikal, no? Andyan ang PhilHealth, medical insurance, social assistance or SSS disability, no? So kailangan natin i-ensure na sila ay may access sa lahat ng ito. Tulungan natin sila. Ang ART, kung maaari ay huwag itigil dahil ito'y libre na lang. Libre naman. Tulungan din natin na kompleto ang kanilang access. Now, for patients who are of a more mature psychological status, we can discuss the living will, advanced directives, having a healthcare proxy, and long-term care. Again, I want to say that it has to be someone who is mature enough to accept that number one, they have HIV. Number two, they will die eventually of old age or whatever. If usually our patients are vulnerable, no? Especially at the beginning. And sometimes even years of being with us, we can see na meron pa rin konting dagok ng stigma sa kanila at maaari meron silang co-occurring mental health conditions which might make them not ready to discuss this. Please always assess your patient's readiness to talk about these kinds of things and provide information. Okay? So, example lang ito. Wala kasi tayong ganito masyado sa Pilipinas. Pero ito ang example ng advanced directives. How do you choose which is the best for you? So, we have to talk about what can happen to our patients that might need this. So, first, kung sila ay in a coma or vegetative state or mentally incapacitated, would they want someone to make medical decisions for them? Hindi yung magsusurvey ang doktor sa ospital kapag comatose ang pasyente at saka pa lang sila mag-uusap. May mga pagkakataon na pwede na tong isulat bago pa pumunta sa ganong sitwasyon ng mga pasyente natin. No? Advanced directive yun. So, kung yes ang sagot nila to, ito ay tinatawag na healthcare proxy. Kung no naman, then kasi wala silang tinatrust to act as their healthcare proxy, consider a living will. So, still these are things that should be discussed with a lawyer. Especially pagdating sa mga sitwasyon na hindi alam ng pamilya. No one in the family knows na may HIV ang pasyente. It's going to be difficult. Okay? So, even though you want someone you trust to make medical decisions, ask your patient kung meron silang strongly held views about specific situations. If yes, they can combine the healthcare proxy with a living will so that the person na i-appoint niya on his behalf can rely on your written instructions. So, siya ang magke-carry out ng mga instructions mo. If no, then yung healthcare proxy ang magde-decide. So, siya yung kumbaga iaasa mo sa kanya. Okay. So, ito lang yung sample ng isang healthcare medical power of attorney with mental health authority. So, sample lang ito sa isang maaring maging healthcare directive or living will natin. So, discussing death is part of HIV care. Death can be present sometimes at the first instance that we meet our patients in the hospital because of an opportunistic infection that is fatal. But if we are lucky, we can be with our patients for longer and have many years with them. But then let's take this opportunity also to discuss end-of-life care with them when they are ready. So, aging in HIV is something that is not yet well-researched, very few evidence for it, but it's an inevitability. And I think we should all prepare, even at this stage that we are seeing mostly young patients. Because if we believe in the medicine, in the ART, then they will reach that age. Thank you.